Adrian, what sutures do you use, when, and what suture materials do you use? Almost exclusively I have used polypropylene sutures for soft tissue surgery. In the past I used to use some gut sutures, but I have less faith in my patient's ability to heal now than I did. I have just trialled some Vilene sutures from Dyneck, which is an Australian suture company. I've tried them, they're quite a lot less expensive than some of the other sutures, and Vilene is really nice. It's not as soft as Teflon, but it's not as stiff and wiry as polypropylene. It's much less wiry than nylon. Now all of these monofilaments work, so whether you use nylon or polypropylene or Vilene or all of the Dylock, all these particular materials are monofilaments and they essentially work the same. It's just how you enjoy using them. Some of them, like nylon, is very, very stiff and wiry and very prickly. William, what are the different grafting materials techniques? What's the pros and cons and applications? Well, there will be a video coming out with all of that stuff. We do have a whole bunch of soft tissue videos, but I've realised that we need some super duper basic ones just for the absolute basics, and that will be coming out in the next sort of 6 or 8 weeks. So be on the Academy and keep an eye on when that comes out. Clive says, is it okay to place a graft over composite material or some other restorative material surface where there is a big recession? And the answer is actually yes, you can. But there are some criteria. So I have had patients get attachment to amalgam, I've had them get attachment to composite resin, I've had them get attachment to GIC, and there is research showing that you can even get hemidesmosonal attachment to gold. So a lot of our theory about how deep restorative materials can go is actually based on having very poor margins. When you have something that's absolutely smooth and flush, then yes, you can get attachment to it. So I have done some grafts that go over composite resin cores. If the tissue is thick, the core is absolutely seamless with the tooth and it's clean, then quite often you will get attachment to that as if you would. It's not going to be as good as if it's to dentine, but you will get that. There's a little bit more detail, and this particular course is really focused on why, and why to incorporate this more often. Lynn says, soft tissue graft, how do I choose between the materials on the market? Most of the materials you will use for soft tissue grafting come from the patient, so your first choice should always be the patient if you can. If you can't use the patient, the only material that has long-term follow-ups that I know of, and when I say long-term follow-ups I mean 20 years plus, is Illidan. So it's an acellular dermal matrix. I mean, Illidan's been used millions and millions, it's been used like 5 million times or something for dental cases, but it also gets used for hernias and breast cancer repairs and all sorts of things. So it's got a very, very long track record, but it has been used for a long time. Now, there are other grafting materials, soft tissue grafting materials on the market that have been around for a very short time, and I personally would not use any of them, because if you put a patient through a surgery and it doesn't work, the patient can be quite sad, and so can you. And the main reason we're using these is not for the patient's sake, it's actually for our sake, because we're afraid to harvest their tissue. So just remember, you're a surgeon, you cause pain, get over it, okay? You won't feel it. Emmanuel, with your very tough or novel cases posted, how do you decide on the treatment on the spot? I don't decide on the treatment on the spot, I decide on the treatment before the spot. So it's planned, and then I sit there and think about carefully how I will do the procedure on this particular patient. And then I visualise the treatment before I actually do the surgery, particularly if it's under sedation where I have a time limit, which, to be fair, I have stopped doing. Rajesh says, what's your opinion about grafting sockets after extractions? Well, I don't generally soft tissue graft sockets after extraction. I do often bone graft them, and I think it's a terrific idea, and my favourite way to do that is to put the graft in the socket and to put a Teflon membrane over the top. I get results with that. It's very, very consistent, and it's very, very easy, and I'm probably going to post a case later tonight of just how predictable and nice those results are. Mike says, I have some complication with connective tissue grafts. Any tips for less failure rate? Should the connective tissue graft be buried under the mucosa, or is partial exposure possible? Now, the problem with the word connective tissue graft is that all soft tissue grafts, all the autografts are a connective tissue graft. The epithelium on the palate is about 50 microns thick. So if you do a free gingival graft, then it's a free gingival graft. A free gingival graft is completely exposed. The things that kill the grafts, but a connective, sorry, we'll just stay on this for a moment. The moment you remove the epithelium, by definition, it becomes sub-epithelial. Because the epithelium is only about 50 microns. So anything, if you remove 50 microns from the surface of the graft, then it is sub-epithelial. Now, people tend to traditionally think that sub-epithelial is where you raise the big trapdoor, you harvest the tissue down to the bone, and you put the trapdoor back. But that is not true. That is we've got in the habit of this, but it's sub-epithelial. If you take the graft off the palate and you remove the epithelium, it's sub-epithelial. However, there is a big difference between the surface layers, which are very dense in keratin, and the deeper layers, which are less dense. The deeper layer close to the palate will tend to have some fat on the underside, and it is generally more beautiful. It's more difficult to get a good result because you have to do really massive grafts. So it takes, I think, more skill to get a good result. And in my experience, the resilience of this tissue is not as good. So it looks better, but in the long run, it is less resilient or less resistant to further recession. Now, but if we go into why, if you do a connective tissue graft that's had the epithelium removed, try and cover it where possible. So really try and cover it. Even if the overlying tissue recedes after a week or so, its job at that first part is to provide nutrition to the graft, if nothing else. So if the tissue overlying recedes after a week or two, then by then the graft should have developed blood supply. But if we want to look at why do grafts fail because of, number one is movement. If there is any movement of the graft. So if you can get the lips of the patient and move it, and the graft moves, then there's a relatively good chance that the graft will either be poorer than you expect, so smaller, thinner, it will resorb, it will relapse, or it will just outright die. If it's a free gingival graft and it moves, it will die. Any part of a free gingival graft that moves, it will die. So that's number one. Number two is too thick. Obviously, when we're starting out doing grafts, we tend to make them too small, and so later on we think, I'm a big surgeon now, I will make a massive graft, and you'll take some big thick chunk off their palate because it bleeds like crazy for ages, and you spend quite a long time trying to stop the bleeding because it's pooling in the back of the patient's throat and you're worried about them getting sick. And whilst you're doing this, the graft is sitting on the bench dying, and then you put it in, and because it's so thick, you can't get nutrition into it. So if it's a free gingival graft and it's thicker than 2 millimeters, you won't be able to get the nutrition in through perfusion. So a free gingival graft gets nutrition from perfusion, so just the nutrients perfusing from the blood vessels in the bed or the periosteum into the graft. If the graft is 3 millimeters thick, it's going to die. You can't perfuse that far. Even a connective tissue graft that's going to be placed underneath a flap, if it gets too thick, you can't get blood supply into it and it's too likely to die. Now the third, so there's two reasons. One, movement. Movement is a big killer. Number two, too thick. And number three, okay, I'm sorry, this one I don't really include in the list, but if you leave your graft sitting on the bench for too long, it's going to die, and then by the time you put it in, it's too late. So I always prepare the surgical bed. I harvest the graft, and I usually put the graft in, I just let the patient bleed a bit, and I just put the graft in and I suture it into position, and once I finish that I go back and I deal with the palate because I want the graft to be fresh as possible when it goes in. Even if I don't fully suture it, if I'm going to suture it down like onto the surgical bed, just put a couple sutures in to sit it there, or slide it under the flap with 2 securing sutures either end, and then I'll go back and deal if there's a lot of bleeding. So there's your 4 reasons why they die. 1, you left it out on the bench and it just died. Number 2, it was too thick. Number 3, it moved. And number 4, if it's a free gingival graft, what happens when you create a surgical bed is that you can get bleeding, and then you can get a clot form on the surgical bed. Now, if you get a clot on the surgical bed, clots are designed to stop blood flow. That is their purpose. If you get a clot on the surgical bed and then you place a graft over the top, there will be no blood supply because you have created the perfect barrier to any sort of blood or perfusion. That's the purpose of a blood clot. So if you have a blood clot on the surgical bed, the graft will die because there's no blood supply coming through. That's not such an issue if it's a subepithelial graft where you're pulling a flap over the top, but it's definitely an issue with free gingival grafts. Peter says, when restoring implant crowns, if you used a zirconia abutment, does a polished versus glazed surface affect the soft tissue response? Yes, it does. So if you polish zirconia and it's clean, soft tissue can attach to it with hemidesmosomal attachment. If you glaze the zirconia, which makes it look shinier, it won't attach so well. So polished zirconia is better than glazed zirconia. Vivek says, which antibiotic is recommended after soft tissue grafting and for how long? If I'm doing a graft with autogenous grafts, so I've taken tissue from the palate, I would never give antibiotics. You're taking a piece of living tissue, it's full of blood, you're taking it from here and you're moving it to there, it's not attached to the patient for about 7 seconds and then it goes in, or 2 minutes at the most. It's a superficial wound, there's nothing really particularly deep. If you've got any sort of tiny infection, I've never seen an infection with a soft tissue graft taken from the palate, except where it necrosed, so where it died. If you make a soft tissue graft too thick, then it can die, and if it dies underneath the flap, it will look like an infection. The other thing you can get that looks like an infection is if you do a subepithelial connective tissue graft and you don't remove all the epithelium, and you pull the flap over the top of it, then the bit of epithelium that's left can actually form a cyst, an inclusion cyst. And then it will drain to the outside and it will tend to look like pus coming out, and you'll have to anaesthetise the patient later on when it's healed and remove the overlying tissue. So basically I don't use antibiotics. If I'm using Illidan, then I generally will use I'll have to look it up, okay? I can't remember the antibiotic. There's a particular antibiotic that's recommended to use, that's been used in all the protocols for a long time, and off the top of my head I can't think of what it is. And the reason we're using that is because it's an artificial, well, it's not an artificial tissue, it's the collagen matrix from the skin of a dead person, okay? But it is essentially a foreign body going into the patient, and so you have the potential for infection that you don't have with natural tissues. So in general, I don't use any soft tissue grafting antibiotics. Peter says, do you have any thoughts on the Chow pinhole technique? No, I don't have any thoughts. I haven't done the course. The before and after pictures I see look spectacular. However, I haven't seen really any long-term follow-ups by anyone except the person who created the procedure. So that makes me a little bit anxious. In my experience, now this is not related to the Chow technique because I haven't done it, but in my personal experience when I use collagen type materials as a grafting material, well actually the last time I did that I had relapse a year or so later and then I ended up doing an Illidan graft for free to repair it. So I haven't really, I have seen people I trust use cross-linked collagen membranes. So most of your membranes are either going to be cross-linked membranes or non-cross-linked. Non-cross-linked tend to allow blood vessels through a lot quicker, and it's good for bone grafts because you get blood vessels coming into the surface of the graft very early, which tends to give you the harder bone on the surface of your graft much earlier. But because we're not talking about bone, we're talking about soft tissue, a lot of these artificial materials really create a big scar. That's the purpose of them. It's not an ugly scar, it's actually scar tissue that creates the attachment. I have seen some people use cross-linked collagen membranes, but look, when I'm putting patients through a surgery, I want them to be fairly likely to get a good result. Restorative is my next best, which I use when I've particularly got big cases or I've got a patient who is particularly adamant that I can't take anything on their palate, or where the case is not particularly severe but we want it to look really beautiful, because Illidan, if it does one thing, it looks absolutely beautiful. It's probably the nicest looking, I would say it's the nicest looking of the grafts I use, because you never see that transition from the tissue that was there before and the tissue that's there now. Okay, unfortunately there was like a glitch before and we dropped out, and I don't think I have any more questions. So thank you very much for people who are joining. The recording will be up soon and you can watch it then. And if you have any more questions, please send them through to the Academy, and I can do a question and answer session or a video later to answer those questions. And we will definitely have some new videos coming out soon on basic suturing techniques, classifications of the different types of grafts and when to use them, and just some more basic soft tissue surgery stuff to complement some of the other things that we have that are more advanced. Thank you very much for joining us tonight.